So in one of the previous videos, we studied what happens when there is a stroke. I mean, if depending on what artery is affected, we've learned about what the symptoms are depending on the artery. So now we are going to learn about the types of strokes. There are two types of strokes anywhere in the body, in fact, ischemic and hemorrhagic. So whenever there is a clot, just imagine there is some embolus or any kind of thrombus, or any kind of hypoxia, that's going to cause an ischemic stroke. So any kind of embolus, thrombus or hypoxia is going to lead to an ischemic stroke. So basically what happens here is, just imagine there is a clot here. There is any kind of thrombus or any kind of clot here, and that clot is obstructing the blood flow to this region. Therefore, this area is going to be deprived of blood, and this is going to lead to ischemic stroke. So the main treatment should focus on breaking the clot. Break the clot. You have to lyse the clot to treat ischemic stroke. To break the clot, we are going to use a TPA first, tissue plasminogen activator, which is going to break the clot, So we are going to use tissue plasminogen activator to break the clot, that is lyse the clot. And the name of the drug used here is, it can be anything actually, anything that ends with place, alteplase or retiplase in this case, and the time limit that should be given is in between 3.3 to 4.5 hours. So the maximum time that you can hold the treatment is for 4.5 hours. So in less than 4.5 hours, you have to get the CT done, the non-contrast CT, and if necessary MRI, anything, all the diagnostic tests and the confirmation of the diagnosis that it is an ischemic stroke and not a hemorrhagic stroke should be done within 4.5 hours along with the treatment. Diagnosis and treatment should be done within 4.5 hours. And now hemorrhagic. So hemorrhagic, it just means that some artery here, any kind of artery or any aneurysm or any kind of clot, it ruptured, which led to severe bleeding here in this location, as you can see here. So this area of bleeding, this is called hemorrhagic stroke. So what happens is here just imagine there is already a clot broken here. Some clot is broken here, and imagine if you give them another clot breaker like retiplase again. Just imagine giving them retiplase. What happens? Just any artery here, it is going to rupture again. It is going to, if there is any artery, if there is any clot here, it is going to rupture again. So this is going to lead to even more bleeding. Even in this location, it is going to lead to bleeding. So this is going to lead to severe bleeding. So it is only going to worsen the condition and not improve, not treat the patient, but it is only going to worsen his condition. So in a hemorrhagic stroke, retiplase is contraindicated. And you should initially confirm that it is an ischemic stroke and not a hemorrhagic stroke, and only then you can proceed to the treatment, that is TBA or thrombectomy if it goes beyond 4.5 hours. So how do you confirm it? Using a non-contrast CT scan of the head. Non-contrast head CT scan. So in this in the CT scan, you're going to see this. Either the darker location, it is going to represent ischemia, and the lighter location, lighter than usual, it is going to indicate hemorrhagic stroke. Because there is no blood flow here to this location, it is going to be darker. It is called hypodensity, whereas this is called hyperdensity. Since there is a lot of blood here, this is going to be lighter in color as compared to the usual other parts of the brain. So this is called hyperdensity. So hyperdensity. First confirm this is an ischemic stroke and then proceed to the treatment, that is retiplase. And then in hemorrhagic, retiplase is strictly contraindicated. And then you can manage the other conditions. Since in any stroke, be it any stroke, ischemic or hemorrhagic, you are going to have increased intracranial pressure, hydrocephalus, and increased intracranial pressure. So you have to manage this pressure. So to decrease this pressure, you can give him either ventriculostomy. Ventriculostomy is nothing but you go deep inside the skull into any ventricle, third, lateral, third, fourth, any ventricle, and just puncture it and make a hole, so that whatever extra fluid is there, it can be drained outside. Similarly, you can give osmotic diuretics like mannitol. So diuretics, what it does is also the same thing. It removes whatever excess fluid is in the brain. It is going to remove all that via diuresis. And also you have to strictly maintain BP less than 130 by 90 mmHg using nicardipine or labetalol. This is a calcium channel blocker and this is a beta blocker. And another variant of ischemic stroke is transient ischemic attack. Transient ischemic attack. So what this is, the presentation is going to be very similar to an ischemic stroke. The symptoms are going to be similar. Everything is going to be similar to a stroke, to a normal stroke. But the difference is that this is a reversible condition, and it reverses itself within 1 hour of the onset of symptoms. 1 hour from the onset, everything is going to be normal. The patient is going to be normal, like nothing happened to him. You do an MRI or CT, obviously with stroke, any stroke. So now let's talk about hemorrhagic strokes. So hemorrhages are usually two types, hematomas and hemorrhages. Hematomas is nothing but a collection of blood in a particular location, in only one location. So it can either be epidural or subdural hematomas. Epidural is mostly due to any kind of traumas, and subdural is also mostly because of traumas, and also it can be due to age. Age also is a major factor. So one thing you have to notice in the CT is epidural is usually this shaped, convex shaped, whereas subdural is usually crescent shaped. See, like you can see here, epidural is convex shaped, whereas subdural is crescent shaped. So convex here and crescent. And also there's another difference. I mean, this is not a major one, but this matters, that this epidural hematomas are usually smaller in size, whereas subdural hematomas are longer. They are long in size. This is another example. Here also you can see this is crescent shaped. So what is this? This is a subdural hematoma, whereas this is a small convex shaped hematoma. Therefore, this is epidural hematoma. So these are hematomas, and hemorrhages are again two types. They can either be subarachnoid or intraparenchymal. The most common cause of both of these, any hemorrhage, is usually hypertension. So hypertension is one of the leading causes of subarachnoid and intraparenchymal hemorrhages. So in subarachnoid, it is in the name itself, subarachnoid. Sub, it means under, and arachnoid, it means it is one of the meninges, one of the three meninges. So under the meninges. Therefore, you can see here, this is the hemorrhage. This is coming like this from the meninges and again going back to the meninges. So you can always notice that these kind of hemorrhages are always attached to the meninges in one way or the other. In any way, they are attached to the hemorrhages. Whereas this, you can see here, this is an intraparenchymal hemorrhage, and this is from nowhere attached to the meninges. So this is like an independent hemorrhage in itself. So this is one of the main differences you can see on a CT scan, that subarachnoid hemorrhages are attached to the meninges, whereas this is not attached to any meninges. Subarachnoid hemorrhage presents with worst headache of life. You can also call it thunderclap headache. Thunderclap headache or worst headache of life, and it also presents with nausea and vomiting. The most common cause is perianeurysm rupture. So what happens is, because of hypertension, just imagine there is some kind of aneurysm forming here because of high BP usually, or any trauma also, and this perianeurysm, it suddenly ruptures. It ruptures and all of the blood goes like this. It and causes hemorrhage. So this is one of the leading causes of subarachnoid hemorrhage. It is also called saccular aneurysm, perianeurysm or saccular aneurysm. When it ruptures, it leads to hemorrhage. It leads to subarachnoid hemorrhage, and you can usually see it in a CT scan. But even if you do a lumbar puncture to confirm, you can see bloody or yellow colored fluid coming out. Bloody because it is hemorrhage, so obviously blood is going to leak out, and yellow because blood wherever the RBCs are lysed, wherever there is any kind of hemolysis, it is going to lead to indirect bilirubin accumulation. So basically the RBCs are going to turn themselves into bilirubin. Bilirubin is yellow in color. So the lumbar puncture is going to be bloody or yellow in color, the discharge. And intraparenchymal hemorrhage, this is also because of hypertension. And here you can see, this is an intraparenchymal hemorrhage. These are the types of other intraparenchymal hemorrhages. And putamen, here this one, this is the most common intraparenchymal hemorrhage. This is the most common location of intraparenchymal hemorrhage. So internal capsule, here comes the internal capsule, this one here. Putamen is the most commonly affected location. The artery, like here, perianeurysm is ruptured. Similarly, here the artery that ruptures is called, most commonly the artery that ruptures here is called lenticular striate artery. That also is somewhere around here itself, near the putamen itself. So lenticular striate artery ruptures, and then it leads to hemorrhage in this particular location. So it is, you can see here, it is always independent of the meninges. This is the aneurysm here. This is the hemorrhage here, and it is not connected to the meninges anywhere. Even here, you can see clearly here, it is very close to the meninges, but it is not attached to the meninges, unlike the subarachnoid hemorrhage. Here, see, subarachnoid hemorrhage is always connected to the meninges, whereas here there is no connection to the meninges and the hemorrhage. So lenticular striate artery is most commonly affected, and lenticular striate artery is a branch of middle cerebral artery. So now you can this is like summary. Intraparenchymal hemorrhage, the most commonly affected is putamen. The most commonly affected location is putamen, and the most commonly ruptured artery is called lenticular striate artery, which is a branch of MCA, middle cerebral artery. So basically, MCA is the most common strokes in a patient with hypertension. So just imagine any hypertensive patient with a history of hypertension. He comes in with sudden headache, especially if it is thunderclap headache, it is going to, you're going to suspect subarachnoid hemorrhage. Whereas if he comes in and you take a CT, because any patient with headache, you're going to take a CT, and then you notice this kind of a thing. It is going to, it is usually because of MCA stroke. And the treatment is similar to the ischemic stroke. You're going to manage his intracranial pressure and blood pressure. Similar to the ischemic stroke, intracranial pressure is managed with ventriculostomy or mannitol, and blood pressure is managed with nicardipine or labetalol. As we've discussed, this is a calcium channel blocker and this is a beta blocker. And always remember, TPA, that is any places, all the places, alteplase or any kind of place, is strictly contraindicated in hemorrhagic stroke, because it is only going to increase the hemorrhage and going to worsen the condition. So now let's talk about what happens when there is a stroke in the MCA. So we know that whenever MCA is affected, the three parts of the body that are going to be affected is arm, face, and speech. And obviously always contralateral. So arm, face, and speech are going to be the most affected whenever there is a lesion in the middle cerebral artery. So when the speech is disrupted, it is called aphasia. So aphasia is nothing but disruption of speech. So aphasia can be three types. It can be motor, sensory, and global. Motor is when the motor speech center is disrupted. Motor speech center. And where is that located? It is located in the Broca's area. Broca's area. Here you can see this. This is the primary motor center of our brain. This is located in the, you can see it. It is the frontal lobe, and this is the Broca's area. It is the primary motor speech center. Whereas sensory, Wernicke area is located here near the temporal lobe, in the temporal lobe, and this is the primary sensory speech center. So whenever there is an issue, and both of these are supplied by the MCA. So as we know, MCA supplies to this whole region here. This is supplied by the posterior cerebral artery. This is supplied by the anterior cerebral artery. And the whole location here is supplied by the middle cerebral artery. So middle cerebral artery is only going to supply to both Broca's area and Wernicke's area. So superior part of the middle cerebral artery is going to supply to the Broca's area, whereas inferior part of the middle cerebral artery is going to supply to the Wernicke's area. So if there is a damage, the stroke is in the superior part of the middle cerebral artery, it is going to lead to motor damage. That is, Broca's area is going to disrupt it. So what you're going to see is broken speech. So you can remember it like this: Broca's and broken. So let's see what happens exactly. So you know what motor means. Motor is nothing but something that goes that comes out of our brain, outside. Brain to outside, right? This is what motor means. So when your speech is not able to go outside, you can understand, you can take everything outside to brain is normal, is okay. That what that means is what I'm able to tell you, you're able to understand, because your sensory your sensations are right. Your sensations are intact, so you're going to understand what I am telling you. But you cannot tell the same thing outside. You cannot tell anything outside because your motor is disrupted. So you cannot send the proper speech signals outside your brain. So you're going to have broken speech whenever there is a lesion in the superior middle cerebral artery. He understands what we are saying because his sensations are intact, but he cannot speak. This is a video from Tactus Therapy. This is an example.
Mike Caputo.
And when was your stroke?
I was 7 years ago.
Okay.
And
what did you used to do?
Worked Autodesk, 7 sales.
So here you can see that his speech is broken. He keeps using the words and all those words that, they are breaking his speech. His speech is being broken. He's able to understand the questions that the doctor is asking him, but he's not able to say the right words outside. His speech is broken. Therefore, he understands, but he cannot speak. Similarly, Wernicke's area, you can remember, just the way you remembered Broca's with broken, you can remember Wernicke with what. So the patient, now he cannot understand. So outside to brain and then back to outside. So his outside to brain, the sensations are gone, whereas his motor is intact. So what he can say everything outside, but right now what I am telling you cannot understand, because your sensations are disrupted, your sensations are not intact anymore, so now you cannot understand, but you can speak well. Whatever you speak, you can speak well. But what happens is, inferior middle cerebral artery is affected, and his speech is perfect, but it makes no sense because his comprehension is damaged. Comprehension is nothing but the way he understands, his understanding levels are damaged. Therefore, what he says doesn't make any sense. This is called word salad. You can see here. This is a video from the same channel, Tactilo Therapy.
Hi Byron, how are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment. Talk with the people over them over there. They're diving for them at the moment.
So here you can see that his speech is perfectly intact. What he says is perfectly intact. It is not broken like this, but it doesn't make sense. The questions that he's being asked and the answers that he's speaking are totally different from each other. They make no sense. So this is called word salad. So word salad is seen with Wernicke's. What? Because he cannot understand. And broken speech is seen in Broca's area. And when the complete MCA, I mean there is a big lesion in the middle cerebral artery, like here. If there is a big stroke, I mean if the lesion is big, so big that the whole middle cerebral artery is affected, then both of these areas are going to be affected. Then that is called global aphasia. Then the patient is going to present with both motor symptoms as well as sensory symptoms. This is about speech.